So it is audible properly and no disturbances, right?
Yeah, ma'am.
Oh. So we are all live. Welcome everybody. I'm Dr. Gauri. It is audible properly and no disturbances, right?
I think.
Yeah, ma'am.
YouTube.
Yes. So sorry about the glitch. So now we are all set now. I am Dr. Gauri. I'm a child development physician. On behalf of Brain Child Trust, I welcome you all to this wonderful session this evening. I'm not going to stay any longer between you and the session. Now I hand over to Ms. Kausalya, optometrist, to take over the session. Over to you.
Good evening to one and all present here. It's wonderful to see you all. Today we have participants from different professions. It is good to see the enthu in each and every participant in expanding the knowledge. Few of them have started joining 15 minutes earlier also. Welcome you all. Today we all have gathered here to understand the perspective of vision in children with autism. It's pleasure to welcome our speaker, Professor Aditya Goyal. He was graduated from Elite School of Optometry in 1989. He has pursued his MS in clinical optometry from Pennsylvania College of Optometry, USA, and started his optometry practice in 1991. He is a fellow of College of Optometry in Vision Development, and currently is pursuing his PhD and fellowship in Neuro-Optometric Rehabilitation Association. He is the principal in Shankara College of Optometry, Bangalore, and adjunct faculty in Pennsylvania College of Optometry, USA. He is also a faculty in a number of colleges across India. He is the director at Vision Aid, Chennai, Neuropi Private Limited, India, and Binotech, Canada. A warm welcome, sir, on behalf of Brain Child Trust. Now I hand over the forum to you, sir.
Thank you, Dr. Gauri.
1 minute before we start. So just 2 points. Kindly be in mute, everybody. And if you have questions, kindly put it in the chat box and we will address them as we go. And also this is being streamed on YouTube. So if people cannot join here, you can share that to others. Now I hand over. Thank you.
Thank you, Dr. Gauri. Thank you, Kausalya. I'm not an expert in autism, but then we do see a lot of children with autism and try to work with them. And that is the reason why I have put this as autism and vision and autism in vision. So we are not very sure if vision is affected, not affected, what is happening in autism. But I suppose most of the participants, Kausalya, are involved in some medical care?
Sir, most of them are physiotherapists, occupational therapists, neurologists, pediatrician.
Okay. So it's not parents or the
No, sir.
care.
Medical care practitioners.
So I hope all of us are in the same line that we are talking now. And one thing most of us, including optometrists and ophthalmologists, are confused about is the word vision. When we talk of vision, most of us think it is seeing. It is just eyesight. We just write vision, right eye, vision, left eye. Actually, vision is much, much, much more than just eyesight or seeing. Now, eyes act like a camera. They get the images from outside and then transmit it onto the brain. it goes through the optic nerve, goes to the visual cortex, and it is interpreted. It is perceived by the brain. It is interpreted by the brain, and that perception is, in other words, it goes on to the other parts of the body, which results in a motor action. And moreover, it is not the perception which is going from the eye to the brain alone from the optic nerve. It also goes to the other parts of the brain. It combines with the vestibular system, it combines with the speech, it combines with a lot of systems. So, in fact, the 8 out of 12 cranial nerves are involved in vision. So vision is much, much, much more than just seeing or eyesight. And that is where autism is related to, because as far as the eyesight is concerned, a lot of authors have written that they have eagle eyes. They are fantastic in their visualizing capabilities or capacities. So let's try to understand what this autism is all about. And yeah. A very recent systematic review by Zidane stated the prevalence of autism to be 1 in 100 children. This is 2021 statistics, and this has increased from 0.62% in 2013 to 1% in 2021. And very, very recent studies talk in terms of almost about 1 in 40 children. So this percent to 1% in 2021, which is very alarming, 0.38% increase in 8 years. The estimated ratio between male and female is 4.2:1. That is 4.2 males as compared to 1 female is affected by autism. There's a co-occurrence of intellectual disability with autism, which was estimated to be about 33%. CDC, or Center for Disease Control in USA, in 2021 reported prevalence of autism in 1 in 44 children, and the male to female statistics practically remains the same, where it is 1 out of 27 males and 1 out of 116 females were reported to have autism. I'm just talking a bit about the statistics of autism that we usually see. Invariably, children are diagnosed with autism around 4 years of age, though there are ways in which you can possibly look at the certain traits of autism much earlier than this, but then usual diagnosis is around 3 to 4 years of age. All the ethnicities, everyone, every community in the world, and every economic group is equally affected by autism or the autism spectrum disorder. Diagnosed earlier in economically stronger population, possibly because of the affordability of diagnosis at an early age. Possibly they take the child, they are more caring, or maybe they take the child for diagnosis much earlier as compared to economically weaker classes. And early diagnosis is a key to provide better quality of life through therapies and other interventions. Therapies like ABA, speech therapy, occupational therapy, vision therapies benefit children with ASD. Regression in development, that is the speech, social interaction, different skills, that takes place between 1 and 3 years of age. A lot of parents, when questioned, they say, my child was able to speak a little, but it started regressing. He had started developing, he had 3 words, 4 words, vocabulary, even more. The child was speaking, but then it started regressing after that, and now the child is unable to speak. Similarly, the social interaction was much better earlier. Now it has started regressing. Genetic factors have been documented in a lot of cases of ASD. Children who are born with the parents were old, when the parents were old, are more likely to be affected with ASD. Siblings have 2 to 18% chances of being affected. In the case of twins, among identical twins, The other has 36 to 95% possibility of being affected. Among non-identical twins, the possibility of getting affected is about 31%. A lot of research conducted, vaccines were considered to be positive factor for ASD. A lot of research has gone into this, and it has been clearly proven that vaccines are not the reason for ASD. Several children, about 40% with autism, are nonverbal, and 31% have intellectual disability. About 28% of children with autism who are 8 years or older injure themselves by head banging, biting of arms, and scratching the skin. Death by drowning remains the leading cause of death in children with autism who are 14 years or younger and who have run away from home. Now, these are certain facts about autism which most of us might be knowing, but then it is well worth talking or repeating them again, because unless we know these facts, unless we go deeper into it, the problem does not weigh so much on us as much once we know all these facts. Autism generally affects the entire body with comorbidities like disorders of gastrointestinal tract, epileptic disorders, disturbances with sleep, eating disorders, attention deficit disorder, attention deficit hyperactivity disorder, mental disorders like schizophrenia, depression, and bipolar disorders. Now, it is not a few features of autism that are the problem, but then it is the entire body which is affected and can possibly be affected. It may not be affected in every child, but then there's a possibility of it getting affected. The general signs usually seen in autism are lack of interest in surroundings. They are very aloof. They live within themselves. They don't even bother about what you're talking. They don't interact. They have very poor social interactions. They don't like to have very many people around them. They don't interact with too many people. Maybe with a couple of people who are their caregivers, maybe with a couple of people who are, for example, the parents who are going to take care of the needs. Apart from that, most often they have very, very poor social interaction. As I said, a lot of them are nonverbal and they are very poor socially. So they do not communicate too much. They have very poor communication, and they do not talk much. And whatever their needs are, they just ask for their needs and be done with that. They usually fidget with objects, especially the round objects or the rotating objects, revolving objects. They get highly fascinated by them. Flicking of fingers, flapping hands near their face, all these are very common. These are the adaptations, the neural adaptations that a lot of autistic children have. They usually come out of these adaptations, then go into something else. It can recur, it can happen anyway. A lot of autistic children, they have the tiptoeing. They walk on their toes. So I'll talk to you a little later about what we do with vision therapy with tiptoeing. And a lot of them are hyperactive. The parents complain that the child does not sit in one place. He keeps running around everywhere and does not sit in the class, is not stable at all, lacks communication, lacks concentration, is not attentive at all. So those are some of the general signs that we see in autism spectrum disorder. Now, the visual signs in autism spectrum: gaze aversion. They are invariably, they do not look into the eyes. They avoid eye contact. They avoid gaze. And most times they do not look into the eyes of the person who they are talking to. So they look away from the person and talk to them or communicate with them. Lateral vision. Children with autism, they like to see from the corner of the eye. They keep looking from the corner. They have excessive head movements. This is something that we usually see whenever we are working with a child with autism. I, for one, am very particular about seeing the eye movements and the head movements. So we do a test called NSUCO, wherein we are finding out the tracking or the pursuit eye movements or the saccade, which are the jump eye movements. So I'm very particular about that, where we check the pursuits and the saccades and see how the child is behaving. Invariably, most of us, a good eye movement is where we move the eye instead of the head. It is the eye which moves. So if I have to look at my finger, my eye is tracking the finger. But in case of an autistic or a child with ASD, they usually track it with the head. They don't move the eyes. The eye movement skills are not very good, but they do move the head. Similarly, suppose I have to shift from, let's say, my left hand finger to my right hand finger. I'm just going to move my eye. If I'm not too sure if you can see my eye in the camera, but then I'm just moving my eye. Whereas a child with ASD, if you show him an object here and another object, he moves his head instead of the eyes. And these eye movement skills are very, very important, very particular, because it has got nothing to do with the extraocular muscles. It has got nothing to do with the muscles which are moving the eyeballs, but totally related to the neural system, the vestibular system, and the supranuclear areas of the brain. We'll talk about that in a while. They have prolonged fixation on certain objects. They are attracted to certain specific colors, shapes, and they continue to gaze at that. They have very, very particular fixation patterns, and they keep looking at that. So the things like the wheel or the fans rotating, revolving, they keep looking at that, and they have the hypo or hyper fixation on certain objects. That is, certain objects they totally avoid, and a few objects they continue to fixate at them very, very frequently and for a prolonged time. A number of them are attracted towards shining, spinning objects. Quite often, they are highly attracted by shiny and particularly spinning or rotating objects like fans, wheels, etc. I just mentioned that a little while back. And there are a number of them, they are sensitive to light and sound. It's not that they're not able to hear that, but they're very sensitive. So if there's a loud sound, they tend to close their ears. If there's a bright light, they tend to look away. And possibly that is possibly the reason why they avoid eye contact, because the person who they are looking at might be creating an extra sensitivity looking into the eyes, and they avoid the gaze, and maybe that could possibly be the reason why they are able to do that eye contact to an extent with the parents or the caregivers who they're used to. But a person who is unknown or an outsider, they try to avoid eye contact. Now, I was talking about the vestibulo-ocular connection, that is the vestibular system and the eye connection. Now, let us consider the head. So let's say this is the right eye and this is the left eye, and the head moves, rotates towards the left side. So this is my left side, my head rotates here, and I'm fixating at an object. What happens? In my semicircular canals, the fluid movement is on the opposite side. So if my head rotates to the left side, in the semicircular canal, the fluid inside the semicircular canal will move to the right side. Now that stimulates a vestibular nerve, which goes on to the vestibular nucleus over here. And from the vestibular nucleus, the input goes to the medial longitudinal fasciculus to the sixth nerve, and which connects to the right eye, and on the other side to the third nerve, which connects to the medial rectus over here. So it connects to the lateral rectus here and the medial rectus here. Now the medial rectus is going to move the eye towards the nose, and lateral rectus is going to move the eye away from the nose. So when the head moves to the left, the compensatory eye movements are on the right side. That is to maintain the gaze. And this is something which is affected in children with autism because they are not able to maintain the gaze very well. They have excessive head movements. Their eye movements as such are affected, or uh, should I say they are a little poor as compared to what uh, a neurotypical child has. So this is something which is of importance. And mind you, this area is very close to hippocampus and amygdala, and it comes from the brainstem. And that is what is responsible for the balance, the vestibular system, and hippocampus and amygdala are related, especially hippocampus is related to the moods and mood swings, etc., and social interaction, a lot of happy or the sad feelings, everything. And possibly that is one reason why a child with autism displays all these things. And probably that is a reason why this particular connection is affected and the eye movement skills are not very good. Now, some of the features I was talking about, the corner gazing. I was also talking about the hand flipping. They tend to look at the fingers. They tend to keep adaptations in different ways. They keep flicking their finger. They keep looking at the hand, etc. I was also talking about the tiptoeing. So if you see this girl over here, she walks on the toes. Now, what do we do for this? Now, this is because of the sensory issue where this girl is just walking on the toes, and we used a base up yoke prism, and immediately that very second she was back on the foot, perfectly on the floor. And the moment she removed the yoke prism, she was back on her toes. I have a video, sometime I can show you that. I was not able to upload the video on my presentation. But then that's a very interesting phenomenon that we were able to immediately add within a click of a second. She was flat on the floor, and the moment the glass was removed, she was back on toes. Now, this is over here on to my left is a neurotypical child's behavior where there's a good eye contact and the child keeps looking at the eye or the facial features and communicate with the other person. And on my right out here is an autistic spectrum child communication where the gaze is all over the place and very, very few on the head or the eyes. And invariably, what we see is the gaze is usually not even on the eyes. Even if it is on the face, it is somewhere around the lips that they keep seeing, and they do not make an eye contact. What do we do with vision therapy? We work with fixation skills. I told you the fixation is pretty poor. We work with eye movement skills. Again, the pursuits and the saccades that we talked about. The convergence is pretty poor. That is, when they look at near, the eyes do not converge very well. The accommodation, what I see is they have a lead of accommodation. They over accommodate for any object. They have visual information processing disorders, and obviously the sensory motor integration, wherein their eye-hand movements or the eye-foot movements or the movements of the other, the motor movements, they're poor as compared to the sensory inputs that they get. Now, I'll go over them one by one. Now, fixation skills. They, like I mentioned, they either have hyperfixation or they have hypofixation. Either they continue to keep looking at an object or they avoid it altogether. Their gaze movements are not very good. They are not able to maintain their gaze. Eye movement skills, we do a test called Ensuko test. I'll just show you a picture if I have. Yeah. If you see over here, this lady is holding a bob with a yellow and a bob with a blue in each hand. And all we do is we ask the child to look at this and look at this. Now, if you see this over here, she is looking, but the head has moved. And the moment she says, look at the yellow one, again, the head will move and look at that. And this is for the jump eye movements. When we look at the tracking eye movement, that is, we move this one of them and keep it in different positions. I mean, keep rotating it. The child tracks it with the head and not the eyes. So that is how we check the eye movement skills. There are different tests to check them, but most of the tests are verbal tests. And like we said, a lot of autistic children are non-verbal, and these tests require verbalization as well as comprehension. So most children with autism spectrum are not able to verbalize and they're not able to comprehend. So most of these tests, they are unable to check that. So the good test that we see is NSUCO test, which I just showed you, wherein you can find out the eye movement, which is the tracking movements, as well as the jump eye movements, and you can check them. We also created, using eye tracker, we also created a program wherein we could find out the eye movement skills objectively without any verbalization, without any comprehension. But we just projected some images and we were able to check that and find out the exact fixation and also the eye movement skills. I was talking about convergence. Now, probably because of the avoidance of gaze, probably because of the way they look at objects, they have poor convergence. And to counter convergence, poor convergence, the accommodation overacts and they are over-focalizing. And that over-focalization could possibly be because of poor convergence. It could be vice versa too, but then we don't see these children. They are fixating at objects. So we presume that it is a convergence which is leading to the poor convergence, which is leading to excessive accommodation. Visual information processing, they're not able to process a lot of information. And that is one thing which we do work on. And again, we work on the eye-hand coordination and different skills. Now, I was talking about vision therapy and how does vision therapy work in general. A lot of people think that vision therapy that we do is voodoo, we do some black magic, we do something. It is pure science. We work on top-down processing, we do not work on the muscles, where first is a verbal cognitive phase. I'm providing a feedback to the patient. And with that feedback, the patient understands whether the activity or the task that he or she is doing is right or not. So first I provide a feedback that the activity or the action that was required has not been done properly. We show them where the problem is and also the corrective feature. So the brain starts understanding that there's a problem. I'm not able to do it properly. I need to change the way I do. For example, let's say while developing, a child has to start walking. He understands that there's a certain way. He gets up, falls, probably tries again, gets up, understand where the mistake is, and then a day comes when he is able to get up perfectly well. While taking steps, again, he keeps making mistakes. He topples over. Over a period of time, they're able to walk. Similarly, when a child in vision therapy or an adult in vision therapy, something they have learned wrong, that has to be rectified. How that is rectified is by providing a feedback. First of all, I got to know that I am not doing something correct. I need to rectify that. And I'm shown the possible correct way of doing it. That is verbal cognitive phase. Then the next one is associative phase, where I continue to practice that over and over again. And ultimately, we lead to something called autonomous phase, where the things become automatic. A simple example, like I talked about walking, a child learns to walk. First, the child learns to sit up, then the child learns to get up, and then the child learns to walk. And over a period of time, the child learns to run. When we learned our alphabets, we didn't learn it on the first day. We made lots of mistakes, each of us. But today, all of us who are sitting over here, we do not repeat or learn or relearn our alphabets every morning. We have got into autonomous phase. We went through the verbal cognitive phase, where we were told what we are doing is wrong or whatever we were doing was right. And that went on to the associative phase, where we practiced it over a period of time. And today it has become autonomic. We do not have to repeat that. We do not have to relearn. So this is the way VT or vision therapy works. And we are working on the first one, which is most important, which is providing a feedback. A feedback has to be provided for the child or for adult to know what he is doing is right or wrong. Secondly, if it is wrong, how is it to be corrected? Then we make the person practice over and over again, and then get him into autonomic phase. Now, these are some of the things that we do for a child with ASDs. A few of them, like I told you about the tracker. Now, this is the eye which is being tracked. This is a tracker over here with 3 lights. It is tracking the eye movement. So what it does is it captures the pupils of the child, and the child, wherever he is looking, you will see certain spots over here, which will be the eye. So we will be able to check where the child was looking, project an object, and check where the child is looking and measure that. There are certain computerized programs wherein we teach them the eye movement skills. This is called a flow rotator. Again, we work on them. Now, you might be wondering, how do I provide a feedback to a child with autism? It's very simple. Now, I said, I do not want the child to make head movements. So let us say on a rotator or on a computerized program or this program, my child is making a head movement while performing certain tasks, while following an object, while making a jump eye movement. What do? I put a bean bag on the head, and the moment the head moves, the bean bag falls down, or anything. You can put a small book or something on the head, and that falls down. And the moment it falls down, the child knows that he had moved the head. And over a period of time, he learns to keep it stable. The bean bag or the book or whatever on the head remains right there, and the eye movements are perfected. We did a study where we found the fixation patterns with the tracker, the tracking device that I showed you, between neurotypical and ASD children who had never undergone any vision therapy. Now, this is the distance between the tracking point and the image. The one in orange, these are for neurotypical children, and the one in deep red, they are the children with ASD who had never undergone vision therapy. Now you can see how far away they were fixating at the object when it was projected, and we were able to measure the distance between the center of the object and where the fixation was. So from this particular plot, you can easily see that the children with the neurotypical children, they were able to fixate at the object perfectly well, or very close to the center of the object. The child with ASD who had never undergone any kind of vision therapy, they had a huge distance between the center of the object and where they were fixating. Now, what we did was we provided them vision therapy, and Now you see the tracker value of ASG with pre and post vision therapy. Now this is pre-vision therapy, the deep red one, and the orange one is after providing vision therapy to the child. Now this is after a few sessions that we noticed the difference, and we were able to find out that the child with who had undergone vision therapy had much better fixation patterns. The eye movements had improved, and once the eye movements improved, we did find a lot of other improvements, especially with hyperactivity, because their fixation skills improved, their eye movement skills improved. When they were much better off with the eye movements and fixation, they calmed down a lot more. We did provide them therapies with yoke prisms. Yoke prisms we do not use only in case of tiptoeing, but we also use in case of a child with hyperactivity or hypoactivity. Now, the way the yoke prism work is because it changes the space and time relationship. We work on the Einstein's theory of space and time relativity, where if the person has more space to be covered in less time, he tends to be faster. Or if he has less space to be covered in longer time, he tends to be slow, or whatever the vice versa could be. Now, what we do with the person with hyperactivity is that he has space which is large and the time is less. We cannot change the time, but we can definitely change the space relationship. So what we do is the space which is large, we shorten it by using something called yoke prisms, and the space becomes small and the time remains the same, so they become a little slow. If they're hypoactive, we work the other way around, where we increase the space and make them faster. So we train the child with this, perform different activities along with the yoke prisms, perform different therapies, and combine them with a lot of other skills so that it avoids the monotonicity of the task. And over a period of time, we are able to get very, very decent results. So this is what we do with vision therapy. The results are right in front of you. And this is after a few sessions of vision therapy. And in this study, what we did was we did not use all the possible therapies. We used only two therapies. We used the flow rotator and the Senate vision integrator. So those are the two therapies that we performed on the child. Same amount of therapy, same number of sessions, and the results are there for you to see. Well, so that is what we do. We need to walk along with them. The world is theirs too. Thank you very much for your attention. Thank you for listening. These are my coordinates. I'm happy to take any questions that you may have. Thank you.
That was a very wonderful presentation, sir. It was very crisp and simple. I think for now, we don't have any questions. Participants, if you have any questions, you can put it on the chat box.
You can even raise your hands and have a discussion. In the meantime, does anybody here who are kind of having children who are other therapists apart from vision, the therapist here who are having children who are coming to them, and if you want, you can actually elaborate what kind of a difference you're seeing in these children who are going for this vision therapy. So
yeah, that will be a good feedback for us, because
yes.
we are talking about ourselves, but then we have not got much feedback. So
definitely in our center where your services is available, we actually see and appreciate so much of a difference happening. I think Purva is sitting with you, Kausalya, isn't it? Maybe
Yeah.
2 lines.
Yeah.
She can say. And we are having, I think, people raising hands. After that, we can go to the questions.
So coming from a psychology background, I've seen definite improvements in children who have autism and who come for vision here, specifically here in our center here. One of the major changes, I mean, we assume that the eye contact is the first thing that changes, but even before that, I feel like their registration of things around them, which is why we think that the aloofness kind of reduces. We always feel that children with autism are in their own world. But when they go for vision and when they start registering better, the toys get less preference and the people start becoming more important in their visual field. So when they start registering, then eye contact becomes a bit more easy, and also focus. When we are trying to do a task with them, when we're trying to give them instructions, I think children who attend vision are responding better to instructions as well.
More faster, more easier, isn't it?
Yes.
Yes. Kritika, do you want to kind of add anything here as a feedback?
Yes, ma'am. As a physiotherapist working here, and I have also seen few children with the autism spectrum coming to us. It definitely, vision therapy, the children who definitely go for both therapies, it helps the children focus better, especially children, I think as Aditya sir had mentioned, that these children do have difficulty with focus, have difficulty with, especially with spatial coordination, which is very, very important for us. The children definitely perform much better and are able to focus much better after perform. I have seen personally, these children have performed much better after also with the addition of vision therapy.
Thank you, Kritika. So over to you.
A few questions here.
Yeah.
One of them, Kavita, has asked, if the child is unable to respond to suggestions and very young, then how do you proceed? Very interesting question. Most of the children who we deal with, they are not able to understand. But then, like I said, a simple thing like putting a bean bag on the head, and they definitely understand when it falls down, and they are asked to do certain tasks and make it interesting for the child, and age appropriate and understanding appropriate, and they will be able to do so. I don't think for vision therapy we require any kind of very intricate understanding for the child to understand, to follow what we want them to do. I hope that answers. You can ask. Okay. Now, the second one is Ramya, which is a very interesting question. I'll just go back to my presentation. Let us say this is the object. Now I'll be able to find out the center of this object. Let us say I present a big, okay, let's say this is the object. The center of all the coordinates when we see could be here. And with the tracker, I'm able to find out where the child is looking. So the distance between this and this is what we are talking about in the study. So what we did was, just a second. So what we did was we found out the distance between the center of the object that was presented. So we used objects like fruits, vegetables, and very interestingly, we also used human faces, where we found that they were looking more towards the lips rather than the eyes. Whereas the neurotypical children were looking at the eyes and not at the mouth or the other parts of the face. But then, okay, from the study perspective, we found we had the center of the object that we had presented, and we were able to track the eyes where they were fixating when we presented that object. So we found out the distance between the center of that object which was presented and where they were fixating. So that's what we did, and I hope you have. I hope I have clarified that, Ramya.
You can unmute and respond. Okay, yeah.
All right.
We have one more hand going up. Hema Mohana. Do you want to
Good evening,
unmute and ask your question?
Yes, ma'am. Thank you. Good evening, sir. Thank you for your wonderful presentation. Sir, two questions. I just want to know, first of all, is there any app is available for visual perceptual skills? Because most of us are visual perceptual skills in vision therapy, no? So is there any app available? And also, second question is, is there any difference between vision stimulation therapy and vision therapy? Because they are saying rod cells are getting activated, no? So I just want to know, both are same or both any difference is there? Thank you, sir.
Okay, as far as the apps are concerned, there are plenty of apps. You can just Google for them, and plenty of those the perceptual apps are available. We also have a number of programs, software programs, which are available for perception and vision therapy as such. So maybe I can let you know all the possible programs that are there internationally, as well as the apps which are available. Now, as far as stimulation and vision therapy is concerned, stimulation is a part of vision therapy. So it is a tool that we use, especially in cases of cortical visual impairment or delayed visual maturation, where we stimulate the brain to start work, to make the eyes work. There's nothing wrong with the eyes as such in cortical visual impairment or delayed visual maturation. So that is where we stimulate to make the visual process start kick up.
Thank you, sir. Thank you so much. Sir, is it possible to type any app, available app in the chat box, sir, so that we can note it down? Thank you, sir.
Yeah, I will.
And
Maybe
sir, we have
actually you have everyone's email ID.
Sir?
Whoever have registered through the link, we have the email ID. So
Yes, sir.
we can disseminate these informations to everybody via email. In case
Yeah.
you haven't registered through the Zoom link, please share your email IDs here, and I'll be sharing an email ID here. So you can email us your email us, and we can share the information.
And so we have one request from participant, if we can show the video of your prisms.
Let me just give me a minute. I'm not sure if I can show you my WhatsApp video over here. Can I?
If you go into the web WhatsApp and share that screen, you will be able to show.
I think, give me a minute. Let me
Yes,
try.
please. We have time. You can. In the meantime, Kausalya, you are dealing day to day with these children, quite young children, also with autism and vision issues, isn't it? So cognitively also, there are challenges. So maybe one or two activities, how you tend to engage with them, if you want to enlighten. So one of the previous persons, I think, query we can answer.
Yeah, ma'am. So basically, we select activities depending on their cognition level and understanding. So it is like we innovate a activity depending on how they can do. It is not like we have to do reading activity or we have to do sorting activities. So example, if they can just follow and toys or illuminated, if they have interest in seeing illuminated targets, then we'll do activities, we'll do therapy with illuminated targets. So that's how it works. It is not we don't have any fixed thing. It's like we have to do the same activity and all. It is depending on the kids' understanding level also.
Are you able to see something on the screen?
Yes. we
Yes,
can-
sir.
Okay. Can you see the video?
Yes.
Now I'll take it back. Now, 1 second. Just give me a. Now, what she's wearing is yoke prisms. Now, just look at the feet. The moment she removes the prism, she goes back on her toes. And when the prisms are placed back, now you look at the feet. Now, if you see, she'll remove the prism now. She's on the toes, and as soon as the prisms are down,
Yes, foot are on the ground. Keep coming, keep coming, keep coming. Again, keep coming.
are you able to see that?
Very good. Again, go back.
Yes.
Last time.
The moment she removes the yoke prism, she goes on her toes. I'll play that again.
फिर से आओ बेटा फिर से आओ चलो good now go back
She has taken off the prisms,
just a 20
and the moment she gets the prisms on, she's back on.
foot are on the ground
Yeah.
keep coming keep coming keep coming again keep coming very good again go back last time ke beta
All right. So
So we have one question. So what is the protocol for the glasses and how long is the child expected to wear them?
sorry.
Just a minute. So what is the protocol for the glasses and how long is the child expected to wear them? The yoke prism.
We usually use them while providing therapy. We do not prescribe these glasses invariably. So this is used while providing therapy to the child. And over a period of time, we create a sensory awareness in the child, and they start walking properly. So the amount of yoke prism that we use is considerably high, depending upon the requirement, and these cannot be prescribed as such. So whatever we prescribe are a small amount of yoke that can possibly be prescribed. So about 4 to 5 prisms is a maximum that I would like to prescribe, but I avoid that to the maximum possible.
So we have another question. How can we exactly differentiate it is purely sensory issue or also a visual component?
I didn't get you.
So if there is a sensory issue, how to differentiate it is it purely sensory or it is because of vision?
Vision is sensory, right?
Yes, sir.
So whenever we are talking of vision, we are talking sensory. We are not talking motor at all. So the thing that we are trying to differentiate is between vision and motor. Sensory and motor. So if it is a sensory component, usually I have seen in almost 100% cases that the tiptoe goes away. But then if it is a muscle which is involved, which is a little tight muscle or a shortened muscle, then obviously it has to be operated upon, and the child orthopedic surgeon is the best answer for that, pediatric orthopedic surgeon.
So we have another question. If the child has underlying visual issues, then how do the management strategies change?
Sorry?
if the child have underlying vision issues, then how do the management strategies change? This is from the other therapist, I think.
Okay, whoever asked this question, can you mention your background so we get a better idea of this question? What
We
therapist
don't
are
know
you?
what management strategies
So,
we will
from a physiotherapist point of view, I think.
So management
SLP,
strategy as
speech
such,
therapist.
we are talking of providing vision therapy. The management strategy as such is to add vision therapy to that. As well as what you're doing as speech and language pathologies, we will not change anything with you.
Okay, so maybe I can ask Mabel to maybe share a sentence or two here, because she sees how the vision therapy along with speech therapy is going on. So she may be able to understand the question and answer this better. Mabel, if you don't mind.
Yes, ma'am, I'll take that. Ma'am, so the question I think is about how do we change our management if there's already a visual issue. So a few examples would be like recently we had a child who we are planning hours for. However, the child had visual fixation issues. So child is not able to identify the picture that is of the hours. He was trained to do task per se. So he does task because he has to finish the task. He just wants to get done with the task and move to the next one. So to avoid the task, he will look anywhere and just press swimming. So if the therapist was asking where swimming, he would look, elsewhere and then touch that. So he was referred to me, and we were looking into that. So once we got the entire assessment done, I had referred him to Dr. Aditya, and then we found out he had these issues. So right now we are looking at engaging him in play and just understanding. So there's no motivation from the child's end to communicate because he's already 8. They have tried too many speech therapy programs and that's not been successful. So right now we are trying to bring him back to play to understand the joy of communication. Meanwhile, vision is being worked on parallelly. So as we see vision gets better, we will start introducing more specific AAC tasks with him and take it from there. A few other kids we have looked at changing the activity. So usually I go to Kaushalya, who is our vision therapist, or Kiran, and find out where they are. So there's a lot of back and forth questions that go on, and say, okay, so based on that we decide. So there was a child who came in who couldn't. We had mixed up the task given to the child was from a mixed up pile you have to pick up and segregate to the specific categories that we were giving. However, child was not able to do that because it was a cluttered thing and he couldn't fixate or figure out which was where. So again, going back to, okay, can we reduce the multiple colors, or can we reduce make it a little more visually less stimulating, and then make him do that task. So looking at, okay, where do I change the goal? So that I'll have to alter the goal over there and look at what else can be done. I hope I answered your question, ma'am.
Yeah.
I think there's a add-on. So I meant we'll also have. Okay, Mabel, I'll read this out. I meant, how do we know the child's issues due to fixation or due to visual impairment, that the child is not able to recognize the avas? Right. A child with ASD will also have challenge to, I think, response for visual efficiency test, short or long sight issues.
So yeah, let me take that question. Now, whenever we are doing any of the tests, the first thing that we look for is visual efficiency. So I'm always looking for the refractive error, if it is there or not. If it is there, obviously, if it is a significant refractive error, it has to be prescribed, and we prescribe the glasses to the child. If it is any other issues, which could be problem with the anterior segment of the eye or the posterior segment, we address that issue. Once all that is okay, then we move on to the other issues like the fixation and the eye movement skills, etc. So obviously we are looking at the visual efficiency task first. Then we are looking at if there's any other problem. And thirdly, we look at the visual perceptual issue, because certain visual perceptual issues could be mimicked if the visual efficiency problems. So that is the order in which we go. So we are looking at refractive error, anterior posterior segment, rectify all that, then go on to the accommodation, emergence, eye movement skills, rectify that, and then go on to the perceptual skills. Or could do a couple of things simultaneously.
Sir, I'm sorry. Can I speak?
Yes, ma'am. Please, you can.
Just wanted to ask sir, testing the child for hearing for an ASD child itself, we face a lot of challenge. The child doesn't respond for behavioral testing, audiometry or impedance. The child doesn't respond or cooperate. We end up doing ABR and deleting the child and doing ABR. And that's how we kind of understand what the child's hearing abilities are. The child is not responding for something for an instruction during the session. We don't know if it's because of the hearing issue or because of the child's ASD which is affecting. So similarly, I wanted to understand how do you evaluate the visual abilities of the child before switching to the management strategies for visual fixation and all, sir? First question. Second question, sir, you also said use the what do you call computer training and using the devices. I wanted to understand how does this generalization happen when the parents or the family doesn't have the same device, or they're not able to afford this device, or they don't have that software at home. There's a 1 hour or 2 hour therapy which happens during the session. Will that be sufficient enough? And how do you plan that?
Okay. Your first question was about the evaluation. Now, as far as evaluation is concerned, we try to keep all the tests as objective as possible. So we do not have to rely on patient subjective responses. So every test that we have, we can definitely do them objectively and have good correlated results. So I don't like to rely too much on a subjective response, and my objective findings are considerably fine. So that is how most of the optometrists would like to rely more objectively rather than with subjective interpretations. Now, as far as the second one is concerned, there are different ways. So the recent COVID taught us something very interesting, where we started working on online supervised vision therapies, where if the child does not have, it's okay. They log on to our computer and we are able to provide therapy from our computer. They need not have, most people have simple mobile phones, and we are able to provide therapies through that. And it works pretty well. So what we have seen, the results are fantastic. And we have been, one thing is we are able to provide therapies to people who are far-flung. Secondly, able to provide therapies to the patients who are not able to come to us for any particular reasons. And that's the way we have been doing.
That's amazing, sir. That's good to hear about the second point, sir. First point, first answer, sir. Can I have some tests which you do objectively and 1 or 2 sentences about it? Why? Because when we are counseling the parents of the children, we can tell that, you can go for the visual test and these are the objective tests. It will tell you some information, though the child doesn't cooperate. So just for telling the parents, if you can give us some information.
No, telling the parent for what?
For going for visual testing, sir, because we see the parents hesitate, like even coming for hearing testing, they say the child will not cooperate. I don't want to sedate the child. They don't go for hearing testing. We don't even know if the child is not responding because of organic issues. What do you call hearing?
For example, NSUCO is very objective test. I don't have to tell the patient to do anything. And the parents are able to see very clearly that the child was moving the head instead of the eyes.
Okay.
Okay. If I'm asking the child to fixate at something and he keeps moving away, is not able to fixate for and sustain fixation for considerable time, obviously the fixation skills are not good.
Okay. Okay.
So
So
over here, there is no sedation or anything. It's just
absolutely
having
nothing.
the child and looking at all this.
Yeah. And the selection of objects is very important. So the target that you're showing should be interesting to the child. So we
Okay.
are able to do that, and it works well.
Okay. Sir, if you don't mind, sir, we have one device called pupilometer.
What meter?
Pupilometer, sir.
Pupilometer, yeah.
Software which basically helps in eye tracking the examination of the children. And there are few studies which have been done to see how the child tracks either the reading text or visual audio, something like objects, abstract objects, concrete objects, pictures. All these we
How
have
does it track
done.
eyes?
Sorry, sir.
How does pupilometer track eyes?
So pupilometer has a software, sir. The camera has the software catches the eye movements of the child. We give a stimulus on the screen, and the camera catches the eye movements, and it tells if the child where is the maximum visual fixation of the child. Why is it based on the stimulus we can decide is it concrete objects or animals or pictures what he likes, food items, or is it something like shapes of the geometric shapes? Such studies have been done, sir, where we have seen the visual fixation is more for something which he sees in his surroundings, something like his parents' pictures or animals' pictures, pets' pictures, and he has fixation more for that comparatively, seconds or more.
So
These
that
have
is a comparative way of looking at it. It's perfectly fine. But then when we talk of eye tracking, we generally use commercially available trackers which capture the pupils. When you're looking at the camera, you're broadly looking at the eye movement, but it is not capturing the pupils of the person. What we do with the eye tracker is capture the pupil. So there are different devices. One of them is Visograph or Readalizer, wherein you can capture the pupils of the patient and you know exactly where the patient is fixating.
Okay. Okay.
What you mentioned about the camera tracking, yes, it does. But then that is the entire eyeball which is moving around. So it is, it may not, okay, from the study perspective, it may not be the most ideal thing to use. But yes, it gives you a fair idea. I mean, obviously.
Just wanted to understand if you, if your team and you are doing such studies of eye tracking.
We do use trackers, so we do have commercially available tracker. So we use that. But then, yes, what you're saying gives you a fair idea about where the child is fixating and the interest.
Yes. So
Okay, next question. I think you have asked about Syntonix.
Yes, sir.
Okay. What is the principle behind Syntonix? Do you know the principle behind Syntonix?
I think Miss Gayatri, if you want to
answer. Gayatri?
Yes, sir. I have worked in Syntonix. It's a light therapy. We were given like alpha.
No, what is the principle
beta,
behind?
Light wave.
No, light is not the principle. Syntonix works on autonomic nervous system.
Yes.
Okay. So it is working in the parasympathetic and the sympathetic nervous system. Whereas in ASD, there's nothing wrong with the autonomic nervous system. Why should you use Syntonix? Syntonix works very well where there's a parasympathetic or the sympathetic overload or underload. Right? And Syntonix is in associative kind of therapy. It is not the only therapy. It can be a combined therapy with other things.
Okay.
So in autism spectrum disorder, I don't see any specific role of syntonics because I don't think there's anything wrong with the autonomic nervous system.
Yes, sir.
Somebody said about if a
Hand
child
raised from
has
a
a
participant.
refractive error, how do you work with the yoke prism? So yoke prisms, these are prism goggles which can definitely be worn over the glasses. So you can have your glasses on and in front of them you have the yoke prisms. So that can very easily be done.
So we have a hand raised from a participant. I think Hamshi, you can unmute yourself and
Hello, sir. Thank you so much. It was really interesting. I'm the speech therapist at Astor Whitefield Hospital. My question was, we are constantly telling parents about how 45 minutes twice or thrice a week or four times a week therapy is not just enough and to constantly practice at home or use the strategies to practice. Does that also apply to vision therapy? Is there any strategies or activities that parents will take home to constantly practice, or is it just what happens in therapy?
Well, it totally depends upon, so it is always a discussion with the parents as to how you're going to do it. Because obviously, if I were a parent of a child who has some problem, I would like to say, okay, fine, I cannot come 6 days a week or 7 days a week or 3 days a week. I would like to minimize as much as possible. So it is always a discussion with the parents. So I don't think I have any perfect strategy where I can say that you come so many days and your child will be fine. And first thing I tell them is, I don't think there's anyone on earth who can cure autism. We cannot cure, we are only improving or reducing the difficulties or the problems that are there.
Okay. My question was actually to know that if they are going to continue practicing what happens in therapy sessions, like in their everyday.
At home?
Yes, at home.
Yeah, if
So
it
are
is
there like
required, we do
strategies
that.
that they, yeah.
If it is required, we tell the parents to do that. But invariably, I think what we do is considerably sufficient. If not, if it is not sufficient, yes, we supplement that with certain home therapies or provide certain inputs to the parents so that they can do that at home. Only problem that I face with that is, first thing, I do not know if they're actually doing it or not. Second thing is if they're doing it correctly or not. So that was the reason why we do have a number of home therapy programs which can be done at home by the parent or the patient. But then the only issue that I face with the home therapy programs is I don't know if the child is able to do the program properly or not. For example, if I want the child to look at the screen from 40 centimeter distance and the child is looking at it from 10 centimeter distance, how do I know? So that is the reason why I mentioned a little while earlier that we started something called supervised home therapies, where we are seeing the child, the therapist at the clinic is seeing the child and performing the therapy. So at least we know what distance they are working from. We know if they're doing it correctly or not. Whatever is being done or whatever we want them to do, they're able to do it properly.
Okay. Okay. Another question, it's very related to this question that just like how parents take home strategies or you supervise their sessions and can be done. Generally, when it comes to our therapy sessions, I'm a speech therapist and it's not just speech therapy alone happening because it depends on if the child has any physical disability. There's a physiotherapist that comes in and tells me, okay, what accommodations I can do in the therapy session. If the child has sensory issues, other sensory issues other than vision, vestibular or tactile, we know what strategies we can use in my session. So it becomes a wholesome session. So could we like find out from our fellow vision therapists as to what we can do to help the child, or can we include any of the strategies in our sessions as well? Is it possible? Is it been
Yes,
already practiced?
that is the need of the hour, to have a
Yeah.
multidisciplinary team which is working. So ideally speaking, for every patient, we should have a multidiscipline team meeting where we all discuss our points of view and come to the strategy where, let us say, a physical therapist or an occupational therapist or speech therapist or behavioral therapist, etc., can augment or complement whatever we are doing. That is absolutely the need of the hour, and I'm absolutely in agreement with you on that, that we should have these multidiscipline team meetings. We should understand what the other person is doing and then work around. In certain cases, we can even work together at the same time while, let us say, a physical therapist is doing something, and we provide visual input to the child while the physical therapist is working, or other way around. That works much better.
Thank you, sir. That's all.
Thank you.
So we have another question. So how to differentiate between a visual motor integration problem or a visual perceptual problem?
So there are tests where we do the visual motor. So we have non-motor perceptual tests and motor visual perceptual tests. So you're able to find out if it is a non-motor visual perception or the motor visual perception. So those are the tests that we perform, and we're able to find out very easily.
And so we have another question. Can we use Yoga Prism while a child participate in his classroom activity?
What activity? You're talking of classroom activity in the sense going to the school?
So, Ms. Rashmi, if you can say what therapist you are and where you are looking to apply this, I think we can answer you better.
Yeah, I'm Rashmi Desai. Hello, am I audible?
Yeah, Rashmi.
Yeah, I'm occupational therapist. I'm working with children with autism with ID. So when I say classroom activity, in terms when in the classroom they do art and craft activity or any academic activities or extracurricular activities.
Okay.
Of
So,
coloring, like
I said, we don't prescribe those yoke prisms. As far as possible, we do not like to prescribe yoke prisms. But then, if at all we are prescribing in a very small quantum. So that definitely can be used while doing classroom activity.
Okay. Thank you, sir.
You are welcome.
So I guess we have answered all the queries.
What about this from the manual therapy and computer-based, which is better? Have we answered that?
Oh, okay. Let me take that. A very interesting question. There's nothing which is better, this is better, or that is better. In any therapy, we should be providing variety. So computerized therapies invariably provide better targets because they can change the targets, they can change the color of the target, they can change the form, and also provide a good motion to the target. Whereas when we are doing manual therapy, we are not able to provide all those variety while we are performing the therapy. So both are good. We do both. So it has to be a combination of manual and computer-based, and it's nothing like if you do not have computer-based programs, you should not or you cannot do therapy. Perfectly fine to do anything.
Okay, I think we have another question on YouTube. What is the youngest age to start vision therapy?
For autism? or for anything?
It just states
Okay, let me answer
general
for both.
vision therapy.
Autism, obviously, as soon as he or she is diagnosed, and as far as vision therapy is concerned, I think the smallest baby that I have worked with was 15 days, 15 days old baby, the youngest one. So we can work with any age. Only thing, it is the kind of therapy that you're providing that keeps changing. Obviously, at the age of 15 days, 20 days, 1 month, you will not be able to diagnose autism. So autism, as soon as it's diagnosed, usually it is about 3 years around that, and we are able to start working on them.
So again, I think to add on to that, we are not really looking at certain basic cognitive levels of understanding or anything. So
Yeah.
I think as soon as we kind of pick there as issues, I think therapies can be started.
Yes. Yes, ma'am. Yes.
So anybody else wants to raise their hands and ask question? I think we have another couple of minutes before we can close this. So Professor Goel, any quick takeaway points, and then we can close the session.
Sir, I want to ask one question.
Okay.
Yeah, Rashmi Desai here.
Yes.
Sir,
Go on.
many of autistic children have like eye poking, like they poke their fingers in their eye, or they make their eyeball roll and have double vision kind of this thing. There's a self-stimulatory behavior.
Yeah, it's a self-stimulating behavior.
Yes.
And invariably, it's an adaptation which goes off. But one very interesting thing that we started doing was prescribing glasses, even plain glass, slightly bigger one. And we saw that the eye poking behavior came down. Though that glass had nothing else to do but provide a kind of protection to the child, nothing else. It had no power or whatever. But then we found that the eye poking behavior came down. So I think it is just a stimulating thing, which possibly by providing that glass with a headband, that brought it down. So
Yes. Thank you, sir, because many of them don't even wear glasses, like they don't wear normal glasses also because of many a time sensitivity issues.
I agree. So that's a reason why I said with a belt at the which is wound around the head, and when they're not able to take it off, they get used to it over a period of time.
Thank you, sir.
Welcome.
It was a very informative session. I think everyone got an idea about vision in autism. And now I'll hand over the forum to Mr. Kiran for vote of thanks.
Good evening, all. I would like to thank our speaker and participants. It is such a great opportunity to thank you all on behalf of BCT, and I would like to express my gratitude to our speaker Aditya sir to take out time from his busy schedule for making this webinar great success. I would like to thank Aditya sir for sharing your great knowledge in understanding the visual abilities and challenges in children with autism. I must thank the organizing team and also thank you for all participants and their active participation. Once again, thank you everyone for making this webinar successfully.
Thanks, Kiran. Thanks very much. Thank you, Kaushalya. Thank you, Gauri ma'am. And I don't know if Ravi sir is there or not, but thank you everyone, and thanks a lot for listening to me and also asking fantastic questions.
Yes, it was a wonderful, and interactive session. So I hope everybody has kind of benefited from this. This is again, I would say, the tip of the iceberg. So
Yeah.
as and how things go, you will start understanding much more. And to be honest, I've learned so much working along with these people, and definitely it makes a big impact. So please spread this message, and again, get in touch with us if you have any requirements of us, or Professor Goel coming out and kind of delivering more lectures or more specific topics. We will be happy to help. So shall we stop with this if everybody is okay?
Thank you so much, ma'am. Thank you.
Thank you. Okay.